QR code for those who want to get credit for attendance. I was asked to put it up. Let's talk about diastolic function. There are many things that characterize diastolic function. We'll start with the simple things that can be done, which is measurement of pressures. That purple curve is the left ventricular pressure. And during the isovolumic relaxation, LV pressure drops. It reaches the minimum value called minimum pressure. Then after that first crossover point, the mitral valve opens because at that point or from that point onwards, left atrial pressure is higher than left ventricular pressure. After the pressure gradient is established, flow happens. It doesn't happen at the time of the peak gradient because of inertia. It's usually shortly thereafter. And then ventricular pressure rises. There is a rapid phase when the pressure rises faster. Then the pressure rise is slower. And then at end diastole, or towards the end of diastole, the left atrium contracts, bringing about another rise in ventricular pressure. And the pressure at the end of diastole is referred to as the end diastolic pressure. That plateau phase of left ventricular diastolic pressure is called the pre-A. Why is it called pre-A? Because it's before the atrial contraction. If we shift gears and look at that blue graph showing the atrial pressure, the atrial pressure rises during systole when the mitral valve is closed. The atrium is filling with blood. Its pressure rises. The highest pressure is the V wave. And then after the mitral valve open, the pressure drops, so that's a Y descent. And then the atrial pressure rises again late in diastole because of the atrial contraction after the P wave. Then we have another drop called the X descent. Notice that the dotted line corresponding to the mean LA pressure is lower than the V and the A pressures. Also notice that the pre-A pressure and the mean LA pressure are very similar. When there is diastolic dysfunction, frequently the first pressure to get elevated is the EDP, mean pressures are normal. If relaxation gets worse, if LAP increases, say because of volume overload, then you start noticing the earlier pressures rise. So now there are many measurements that have been looked at over the years. These are the measurements that are recommended in the 2025 guidelines, and I'll spend some time on each one of them. So we'll start with the mitral inflow velocities. Probably is common knowledge now that early filling is characterized by that E velocity and late filling by the A velocity, reflecting the early and late transmitral pressure gradients. Notice that there is a middle phase here where the ventricular pressure is very close or may even slightly exceed the atrial pressure, and you do not see flow in mid-diastole. In normal relaxing hearts, it is possible to get a decent pressure gradient because of a low ventricular pressure and forward flow in early diastole, characterized by rapid ascent, reflected by a short time for that E velocity to reach its peak, rapid descent, short decel time, and the time interval is rather short between aortic valve closure, mitral valve opening. With impaired LV relaxation, ventricular early diastolic pressures are low, transmitral gradient is low, and we have a reduced E velocity, and relatively more flow comes with atrial contraction. Decel time is prolonged, acceleration time from onset to peak of E is long, isovolumic relaxation time is long. To keep LV filling in that setting of impaired LV relaxation and elevated late LV diastolic pressures, atrial pressure goes up. And that will result in an inflow pattern where again early filling is the predominant filling pattern, short decel time, short isovolumic relaxation time. When someone has diastolic dysfunction and has elevated diastolic pressures, in that setting, it is possible to revert from the pseudonormal or restrictive filling pattern to an impaired relaxation pattern with diuretics and vice versa. So that is a very useful finding when you look at mitral inflow. Another useful signal recommended in the 2025 guidelines is the early diastolic velocity, and this is an early study from 1997, where the time constant of LV relaxation was measured with high-fidelity pressure catheters, and that early diastolic velocity by tissue Doppler was measured with pulse wave. And you can see an inverse relation. The longer the time constant, the worse the relaxation, the lower the velocity. Another study that was published in 1997 looked at the relation of that E prime velocity against wedge pressure. You can see a wide spread from 5 to more than 40, and it's a scatter plot, no relation. So if you put things together, we are looking at a velocity that is directly inversely related to relaxation, but is not affected by pressure. Therefore, we can look at the ratio of E to E prime velocity as an index of filling pressure. And this is a large study from the Mayo Clinic where mean LV diastolic pressure, a very close pressure to mean left atrial and mean wedge pressure, was looked at. And the open and the closed circles represent patients with EF 50% or above. The open circles less than 50%, less than 8 mean diastolic pressure, usually less than 15. When the ratio is more than 15, most of these patients have a mean LV diastolic pressure above 15. In between, you have quite a bit of scatter. So that's the story about E prime velocity and E to E prime ratio. How good does it detect an actual elevated left atrial pressure? This is a unique study from 2011 where a transducer was actually in the left atrium in ambulatory heart failure patients. And so they were able to continuously record left atrial pressure, and they show here the accuracy of different parameters in detecting elevated left atrial pressure. These were patients with heart failure reduced ejection fraction. And if you notice, a cutoff of 14 or above for the average E to E prime ratio identifies these patients very well, AUC 0.94. So we covered the mitral inflow, we covered the E prime velocity and E to E prime ratio. The third variable is the TR velocity. The idea is if left atrial pressure is up, to get forward flow across the pulmonary circulation, PA pressures have to go up. And since the peak TR velocity is a reflection of that PA systolic pressure, we can use the modified Bernoulli equation, as in this example, a peak velocity of 3.6 corresponds to a pressure of at least 52 millimeters mercury without adding any RA pressure. Another measurement recommended in the 2025 guidelines, main algorithm for LA pressure estimation is LA strain. And one can think of LA strain as a measure that reflects how much the atrium expands during systole and how much that volume changes later on. This is from an early publication from our group showing the reservoir strain from the lateral wall and from the septal wall of the left atrium obtained by pulse wave tissue Doppler. Nowadays we do it with speckle tracking. And there is the reservoir strain, the pump strain, and the difference between them is the conduit strain. This is an important study from WACE. It's a multi-center, multinational study that took patients without cardiovascular disease, acquired their left atrial strain or volumes, and then the strain was analyzed in a core lab. And it shows you the spread of the normal range of strain across different age groups and in men and in women. And you can appreciate the very wide range of what is normal. So if you have a value less than 20, it's clearly abnormal. To illustrate the challenges with left atrial strain, I will show you two examples. This is taken from a normal individual, high annular velocities, normal global strain, and a strain of 25% for the reservoir LA strain. That's a normal value per these guidelines, and if I present it with these signals, it's a normal LA strain. Let's look at a comparably similar value, very close value, about 25%, But now it's taken from a patient with heart failure preserved EF. Big left atrium, a TR of at least 3.5, pseudonormal filling, reduced annular velocities. If I take away all these signals and just show you the strain, it becomes challenging how to interpret it. Is LA strain an index of filling pressures? The more these pressures, the higher the pressures, be it end diastolic or wedge pressure, the lower the reservoir strain, and this is from an early publication of more than 100 patients. You can appreciate, yes, there is a significant relation, and you can also appreciate the scatter plot. Because of interest in LA strain and its potential shown in this study and other smaller studies, a larger multi-center study with 300 plus patients was conducted. We participated in that study. And similar findings were observed, quite a bit of a scatter. And if you look at the subset of 43 patients with atrial fibrillation, no relation between strain. Further, a deeper dive at where the relation between strain and pressure falls apart. In patients with a reduced ejection fraction, the area under the curve to detect elevated wedge pressure is decent. The same for patients with global strain less than 18%, lower accuracy for less than 50%, and unacceptable performance if you look at patients with a global strain of 18% or above. This is a meta-regression plot done with Dr. Khan when he was with us. And it shows the relation between mean left ventricular filling pressure and left atrial reservoir strain across different studies. The size of the dot relates to how many patients is present. And you can see that this is not a particularly good performance for strain. Therefore, when one thinks of strain, you want to think of values that result in higher specificity. And that ends up being quite a low value for strain. 18% is the cutoff. Let's talk about atrial volumes, another signal recommended in the 2025 guidelines. And basically, this is a graph of the left atrial volume change during the cardiac cycle. During systole, you get to the peak, and then it drops, and then drops further after atrial contraction, and there is the maximum, there is the minimum. The difference between them is the emptying volume. As diastolic dysfunction develops, left atrial size goes up. So it is largest in individuals with grade 3 diastolic dysfunction. So far it's good, but how reliable is LA volume as a metric of filling pressures? This is a large multi-center study that we conducted back in 2017, and it shows the relation between maximum LA volume index and left ventricular filling pressure in 445 patients, quite a bit of scatter, which makes LA maximum volume index one of the weakest, if not the weakest, indices of filling pressure. There are many reasons for the left atrium to dilate. That's part of the challenge. It's not only diastolic dysfunction. Further, when you reach very large atria, it is possible to diurese someone to drop their left atrial pressure to a normal range, but the patient is still left with a large left atrium. Another signal recommended in the guidelines is the pulmonary vein. This slide shows the atrial reversal velocity, but now I want to talk about flow into the atrium during systole and diastole. As left atrial pressure goes up, the proportion of forward flow during diastole exceeds the proportion of forward flow during systole. And that's an indicator of elevated left atrial pressure, reliable in individuals who have a depressed ejection fraction, specific if you see it in someone with diastolic dysfunction and normal ejection fraction, but can have low sensitivity in normal EF cases. That's also one of the signals recommended in the 2025 guidelines. Another one is the isovolumic relaxation time. The isovolumic relaxation time, as we talked about it earlier, gets shorter when left atrial pressure goes up. And the way we record it is we put the cursor using continuous wave Doppler midway between the LV outflow tract and the anterior leaflet of the mitral valve, so we are able to record both. You bring down the scale as needed, and you adjust the baseline so this time interval becomes clear. This is the earliest study from this lab back in 1995, showing how isovolumic relaxation time relates inversely with the pulmonary artery occlusion pressure. Again, the challenge with this particular signal is some degree of spread, and the fact that the isovolumic relaxation time is not just affected by LAP, but also LV relaxation and LV afterload. So these are the 2025 guidelines, the algorithm for estimation of left atrial pressure. It starts with these three signals: annular E prime velocity, E to E prime ratio, PA systolic pressure, which is the more reliable metric of pressure, and then peak TR velocity if I do not have a method to estimate right atrial pressure. If we end up with all of them falling on the normal range, then we call this normal diastolic function, normal LAP. If all of them are abnormal, then LAP is elevated, and depending on the E to A ratio, we call it either grade 2 or grade 3. If we end up with a mix of values or missing signals, then we go to that purple box and we look at pulmonary veins, systolic diastolic velocity ratio. We look at the left atrial reservoir strain. We look at LA maximum volume index and isovolumic relaxation time and other signals if needed. At the end of this phase, we will either place someone into the increased LAP or the normal LAP group. If we have patients with only reduced E prime velocity but E to E prime ratio and TR velocity fall in the normal range, then we go that route and we look at the E to A ratio. If 0.8 or less, then LAP is normal, and this is grade 1 diastolic dysfunction. In addition to in the 2025 guidelines that was not included in the 2016 guidelines is the diagnosis of heart failure preserved ejection fraction. Part of the evaluation is clinical, and then a comprehensive echocardiogram, and we want to rule out significant valve disease, significant CAD, infiltrative disorders, pericardial problems. And after that, we apply that algorithm I just showed you for left atrial pressure estimation. If the left atrial pressure is normal at rest and someone is symptomatic, we do a diastolic stress test, either exercise echo or a right heart cath with and without exercise, and then we would reach the diagnosis, either heart failure preserved EF or non-cardiac dyspnea. Looking at some examples, this is somebody who's hypertensive, EF 66, older age group in the 60s age. And we look at the mitral inflow, pretty high E to A ratio, reduced annular velocities, and a TR of 3.4. So we go here and we say all three signals are present. LAP is elevated. Since the ratio is more than 2, then this patient has grade 3 diastolic dysfunction. Another example, someone who presents with shortness of breath, and there is the mitral inflow. Notice that the ratio is less than 1, but the E velocity is not a small value. It's about 75 to 80. The TR is incomplete, the LA is large, the E prime velocity is reduced, and these are the actual values. So if we go in here, we say we have reduced E prime, we have elevated E to E prime ratio, but I have an incomplete TR. Therefore, I go to that middle box, the purple box, and we identify that abnormal finding of enlarged left atrium. So it takes us to the conclusion that left atrial pressure is elevated. And with an E to A ratio less than 2, we conclude that the patient has grade 2 diastolic dysfunction. This is the wedge pressure recording from that patient. Very nice wedge pressure recording because it shows both A and V waves. And you see the drops in pressure after their peaks, and you see a mean that was in the high 20s. Let's look at another case, somebody with a depressed ejection fraction, very high E to A ratio, minuscule E prime velocity, big left atrium, a TR approaching 4. Doesn't take you much time to look at these, right? And that's a quick summary. And we say all three values are abnormal. In this patient with heart failure, reduced EF, LAP is up, is restrictive filling. And again, we show you the wedge pressure recording, and it's in the mid to high 20s for the mean wedge pressure, confirming that echo got the correct conclusion. These guidelines accuracy was tested in a large multi-center study, 951 patients, and that shows you the performance of the 2025 and the 2016 algorithms, significantly higher accuracy, mostly because of a higher sensitivity. Also in the group with EF less than 50%, which were about 24% of the sample, the performance is better, but these differences did not reach statistical significance, largely because of the smaller sample size here. Let's talk about hemodynamics during exercise, because there are individuals that we want to do a diastolic exercise echo. So the normal response for exercise is that the heart rate increases, left ventricular contractility increases. As a result, the stroke volume increases. If you increase both heart rate and stroke volume, then cardiac output goes up. Stroke volume increases because of increased contractility, but we have to maintain LV filling. If the left ventricle is underfilled, even though it contracts more, the stroke volume won't increase. So how can the ventricle maintain this filling? It maintains it by keeping its pressures low during exercise, because it relaxes faster. And as a result, because of the lower pressures, early pressures in the ventricle during exercise, we are able to maintain LV filling through the mitral inflow. And that happens without an increase in left atrial pressure. This is an example from a patient who's doing a supine bike exercise at rest, 75 watts. Notice the ventricular systolic pressure goes up with exercise as expected. The minimum pressure is 0 at baseline, becomes sub-atmospheric with exercise. And this is a dp dt versus time. This is the negative dp dt. Notice the faster heart rate with exercise and the much higher negative dp dt. Here it's about 3,000 something. This is 4,000 plus millimeter mercury per second, showing you that relaxation augmented. In comparison to that normal response, this is someone who at baseline is doing okay, minimum pressure 1, EDP 11. They exercise, systolic pressure goes up. Notice the difference in scale. At baseline, it goes to 138 with exercise 194. The green line marks end diastole, the blue marks end systole, and notice the EDP now is 16. The minimum pressure is 16 and the EDP is 30 millimeters mercury. This patient couldn't engage much and had to stop exercise. So that's someone with heart failure, preserved EF. In the echo lab, we do the diastolic stress test using a supine bike, because that gives us enough time to acquire images for 2D assessment as well as Doppler signals. The earliest report of a diastolic exercise echocardiogram came from the Mayo Clinic and was published in 2005. This is a patient with hypertrophic cardiomyopathy without obstruction. Notice the ventricular and aortic pressures are identical for their peak, and there is the mean LA pressure of 17. When that patient exercises, LAV wave goes up, and the mean LA pressure is 31 millimeters mercury. Still does not develop dynamic obstruction. If we look at what happens in the mitral inflow velocity, it goes up with exercise, whereas the annular velocity is reduced at baseline and remains reduced throughout the exercise and recovery, such that the E to E prime ratio goes up, mirroring the change that you saw in mean LA pressure. More data still from the Mayo Clinic, more recent 2017, showing what happens to the E to E prime ratio, septal and lateral at baseline with exercise 20 watts and with peak exercise significant correlation. So that change in exercise E to E prime ratio is tracking what is happening to the mean wedge pressure with exercise. Looking at some Doppler examples, this is a patient at baseline, looks impaired relaxation, low E prime velocity, TR at most 2.5. With exercise and a supine bike 25 watts becomes very short of breath, predominant filling in early diastole, a hint at an L wave that is about to develop, E prime velocity that remains reduced, pretty high ratio, and a TR that approaches 4 meters per second. If we have a finding like this, this is solid heart failure preserved EF given the clinical context. Another example of a patient 25 watts and recovery 2 minutes. Notice the increase in E to A ratio, and more important, the peak E velocity approaching 1, and the septal E prime velocity remains reduced less than 5. So we end up with a ratio of at least 20 at peak exercise compared to baseline when that ratio was normal. There are supplementary methods that are recommended in the 2025 guidelines for estimation of left atrial pressure, including PR and diastolic velocity, pulmonary vein atrial velocity, duration of mitral inflow and diastolic mitral regurg, L velocity, and changes in mitral inflow with Valsalva. The PA diastolic pressure in the absence of pulmonary vascular or parenchymal disease tracks the left atrial pressure. It's few millimeters mercury higher. That's an example of a patient with PR and the end diastolic velocity of 2. If we do the modified Bernoulli equation, the PA diastolic is at least 16, and this individual likely has an elevated LAP depending on the clinical context as well. Patients with heart failure preserved EF frequently have volume overload throughout their circulation, and so their right atrial pressure is elevated as well as their wedge pressure is elevated. These are actual pressure measurements from 100 patients who underwent simultaneous echo and cath. Some had heart failure preserved EF, some did not, and you see a significant correlation, albeit there is a spread where some patients have one pressure elevated and the other is not. Example from a patient with heart failure preserved EF is shown here. High right atrial pressure as well as a high wedge pressure. I bring this up because the assessment of right atrial pressure should be factored as well when we think about left atrial pressure, and certainly for the estimation of PA systolic pressure. There is that big atrial reversal velocity that tracks very well the EDP. The challenge is decent acquisition, and so to get a decent acquisition, I have to have the sample volume 1 to 2 centimeter into the pulmonary vein, and then we adjust the baseline so we can see the peak. Sometimes I see a signal where they cut here, so we do not know what the peak is. This is not good. You have to show the peak, and you have to have a sweep speed of 100 millimeter per second so we can measure time intervals. The longer the atrial velocity, the higher its value, the higher the EDP. Patients can have what we call pseudonormal filling pattern. Pseudonormal means it looks like normal, but this patient actually has impaired relaxation, and the reason their mitral inflow looks this way is because their left atrial pressure is up. If they do Valsalva, that decreases the venous return, decreases the filling of the left atrium, decreases the left atrial pressure, that inflow pattern becomes one of impaired relaxation. If you see this, this is very specific for a high left atrial pressure. The L velocity is a velocity that occurs in diseased hearts because of impaired but still ongoing LV relaxation, a high left atrial pressure, and a slower heart rate. A value that is pathologic is more than 50 centimeters per second, as in this case, which is about 60. And it can also be recorded in the annular velocities, albeit its significance is more with the mitral inflow. This is a mitral inflow signal taken from a heart transplant patient who was short of breath. And at first you would say it's a single velocity, right, E, and I'm showing you the E prime at the septal side, which is very small. So that alone tells you that the LAP is elevated. But if we drop these two observations, there are two other very valuable observations in this signal. First, if you take a careful look, whether here or at the level of the annulus, the duration of diastolic filling of the ventricle is very brief. Why is this the case? Because ventricular late diastolic pressures are up, and there is a small or no pressure gradient actually for flow to go into the ventricle. In addition, what these arrows are showing you is diastolic mitral regurgitation. Blood is going back from the ventricle into the atrium as an indicator of elevated late diastolic pressures. So when you look at mitral inflow, there is a lot to look at and digest. Don't just look at that peak velocity. Something from the 2025 guidelines is the algorithm for estimation of left atrial pressure in patients with atrial fibrillation. This was validated in a multi-center study and overall has modest accuracy in the mid to high 70s. It relies on mitral E velocity, septal E to E prime ratio, peak TR velocity, or better still, pulmonary artery systolic pressure and decel time. If 3 or more are abnormal, meeting these cutoff values, then LAP is elevated. If none or only one, and these were signals that were all acquired, then LAP is normal. In between, we go to that another purple box, but smaller box, looking at Lars pulmonary vein and BMI. For many of you, you are aware that individuals with a large body mass index in that range are at higher risk for heart failure preserved EF. An approach recommended in the 2025 guidelines is for patients with pulmonary hypertension. If you see someone with pulmonary hypertension, start by looking at the mitral inflow. If it's an impaired relaxation pattern with a low E velocity, 50 at most, then LAP is normal. If it is restrictive filling and E prime velocity is reduced, this is LAP, and this is group 2 pulmonary hypertension. In between, we want to look at left atrial reservoir strain or lateral but not septal E to E prime ratio. Left atrial reservoir strain at most 18% or a lateral E to E prime ratio more than 13 favor an elevated LAP. Outside these ranges, you may end up with an indeterminate conclusion. In patients with moderate or severe MAC, we start with mitral E to A ratio, and depending on the ratio, we may arrive at a conclusion. In between 0.8 and 1.8, then we look at isovolumic relaxation time. Some of you say cannot assess function because of MAC. That's incorrect. You can assess LAP, okay? So please be aware of that. Heart transplant recipients are a more challenging group of patients. I'll show you some data from our group here. That shows the relation of BMP when BMP was what used to be measured instead of NT-proBNP against wedge pressure in this hospital. And there is a significant correlation, but obviously a widespread that doesn't help you much in an individual patient. E to E prime ratio is significant, 0.55, but again some spread. We looked at a direct index of LV diastolic function. The more you go to the myocardium, the more direct you are. We are not looking now at flow inside the ventricles across the valve, annular displacement, PA pressures, LA behavior. Now I am looking at a signal that I am getting directly from the muscle itself. And that shows the strain rate curve. And we have systolic strain rate during isovolumic relaxation, and early diastole and late diastole. That signal relates well with invasive indices of LV relaxation, be it the time constant or negative dp/dt. These are data from an animal model. And so we can use that index as a metric of relaxation, and this shows you its relation with the time constant of LV relaxation in 50 patients. And I can do an E to strain rate signal during isovolumic relaxation and related to mean wedge pressure. The challenge with it is it needs a decent frame rate, a good quality image, and certainly takes more time to analyze. Why I bring it up is because we used that signal in the transplant recipients, and again, significant correlation. And we have that algorithm, which is included in the 2025. You start with E to E prime ratio. If the ratio is less than 7, LAP is normal. More than 14, it is elevated. 7 to 14, you look at the ratio of mitral E to strain rate during isovolumic relaxation. If you don't have that, then you go to TR, and more than 2.8, LA pressure is elevated. If it is less, then it is not. Some examples: this is a patient with an E to A ratio that falls in the normal range, decent E prime velocities, septal and lateral side. The ratio was 6, and so LAP is normal, which was the case. This is that patient using the strain rate signal during isovolumic relaxation. The different curves were taken from different segments, and then the dotted white line is the global strain rate curve showing you where the isovolumic relaxation is taken and where the early diastolic velocity is taken. LVAD recipients is the last group of patients I will cover. Dr. Mawash covered these in her talk about LVAD, but many times we see patients who have received an LVAD and we want to know what their left atrial pressure is like. That algorithm is similar to the 2016 algorithm in that it relies on mitral inflow as the first step. These are very sick hearts, so I don't need to ask the question, is their relaxation impaired or not? And if we have an E to A ratio that is more than 2, we only need one abnormal parameter from the second stage to make conclusions about the left atrial pressure. If the RAP is more than 10, if the PA systolic is more than 40, if the LA maximum volume index is increased, and if the E to E prime ratio is more than 14. If this is the case, you can say augment medical therapy or increase the pump speed, and you can evaluate the response. If the ratio is at most 1 and you do not see any of these signals indicating a high wedge pressure, then their wedge pressure is likely not more than 15, and you do not need to change therapy from that point of view. In between, you need to look at these parameters, and you need at least 2 to tilt the balance one way or the other. Example from a patient with a wedge pressure of 9 is shown here, ratio less than 1, E velocity 7, E to E prime 9, TR 2.4, normal LAP. In comparison, this is someone with a ratio of 2, E to E prime of 15, and a TR of at least 33 with an elevated RAP, so high wedge pressure. Okay, so we covered a lot today. In assessing diastolic function, we always start with the clinical context, and we look at the vital signs. The heart rate and the blood pressure affect the velocities and the time intervals that we measure. These are the key signals that must be acquired: mitral inflow, mitral annulus tissue Doppler velocities, peak TR velocity. We need to look at the right atrial pressure assessment, so good subcostal views. Pulmonary vein acquisition, dedicated LA views that do not foreshorten the left atrium, LA reservoir strain, and isovolumic relaxation time. Because I do not know what quality these signals will be like or what limitations they may have in a particular patient, I want to get all the other supplementary signals as well. At least be able to show the PR, pulmonary regurgitation, and show that atrial reversal velocity. If your patient can do a Valsalva, good. Remember, there are algorithms for special populations that we covered, atrial fibrillation, MAC, and so on. Always scrutinize the signals carefully. You should use a common sense approach when you apply the guidelines. And when needed, you can recommend a diastolic stress test or cardiac catheterization. Thank you. So we are estimating LAP. To assess pure diastolic dysfunction, if we are talking about LV relaxation, we look at the septal E prime velocity. A velocity less than 7 centimeters per second is considered abnormal across the board, but there are less data about the confidence and the range of how much that velocity should be, say, in an older individual as opposed to a younger individual. If you have 7 in somebody who is, say, 50 years of age, that's abnormal, for sure.
So at the end, if I were to determine that a patient has elevated LAP with atrial fibrillation, my report should just say elevated LAP. I should skip commenting on.
If you are not comfortable about, say, a comment about whether relaxation is impaired or not, is LAP, and that applies for all cases. If you are not comfortable about relaxation for one reason or another, but you're comfortable about LAP, then do that. Good question. The septal velocity is affected by the RV and the LV. And in individuals with non-cardiac and even with group 2 pulmonary hypertension, there can be RV dysfunction. And in these cases, there are often big differences between septal E prime and lateral E prime. If you end up using the average, you may end up with a high E to E prime ratio. But this is because of that very low septal E prime. Yes, it is in the 2025 guidelines in that purple box. I'll go back to it. Sorry, I went fast through it. This is for LAP. We'll try to go to the main algorithm to show where LA strain is. I don't know if they see my slides or not. Doesn't look like it. But yes, it is in there, and I would say that LA strain is more reliable than LA volume index in terms of relation to mean left atrial pressure. You're welcome. Yes?
Is there a reason that the pulmonic vein ST ratio cutoffs are different for your main algorithm and for the atrial fibrillation algorithm?
So let's talk about where these numbers come from. First, I'll start with the main algorithm. So this is based on data looking at something called systolic filling fraction, which is the ratio of systolic time velocity integral of that systolic velocity of pulmonary vein divided by total forward flow, systolic plus diastolic. An important study showed that when this ratio is 40% or less, LA pressure is elevated. If you convert this, instead of a systolic divided by systolic plus diastolic to just systolic over diastolic, you will end up with that 0.67. This is where it came from. The other one in the patients with atrial fibrillation came from this multi-center observational studies where ratios were obtained, the data was examined, and that was the best cutoff. In general, when there is atrial fibrillation, the pulmonary vein and the hepatic vein S to D ratio will be reduced. Why? Because part of the reason, or one of the reasons for forward flow into the atrium is LA relaxation. And if there is AFib, there is no contraction, there is no that phasic drop in LA pressure. And that's why it is not that reliable of a signal by itself in atrial fibrillation.